So I feel really good now. I feel like I know a little bit more about, we all know a little bit more about who is in this living room today. And that's really how I like to think of it when I, in a large group of people at a conference or a talk or something like that. I like to just imagine that we are all in a living room, in community together, to learn from one another. And it's always helpful to know a little bit about some of the people who are, visiting the living room. So thank you so much to everybody for sharing a little bit about why you're here. And hopefully you'll have more opportunity throughout the day to share amongst each other and feel comfortable and hopefully glad to be here. So we're going to kind of do a little bit of a shift now to some facts and figures. Most of the day is focused on moving towards equitable bereavement care, but we're going to start, I'm going to start by orienting us a little bit to why stillbirth matters for health equity at all. And so this will be a little bit heavy on the facts and figures to kind of ground us all and orient us all. And I'm very happy to take any questions along the way. So please just it's a living room, interrupt me if you have any question or comment, or if anything I'm saying is unclear. Because sometimes when you talk about something a lot, you kind of get lost in it, and it's easy to forget how it might sound to other folks who maybe some of this is new to you. So in any case, okay, got my script here so I don't forget anything. I do always like to start with definitions just to make sure we kind of know what we're talking about or using the same definition. Please feel free to come on down and sit, and welcome. So stillbirth is the death of a baby before or during birth. And the difference between stillbirth and newborn death is just survival status at birth. Did baby take a breath or not? Did baby show signs of life or not? The difference between stillbirth and miscarriage is gestational age at birth. And, there are different ways, different thresholds that are used to differentiate between stillbirth and newborn death. The World Health Organization uses a threshold of 28 completed gestational weeks, and that's mainly because data on stillbirths or births, fetal deaths before 28 weeks are pretty poor quality around the world. And so that 28-week threshold is partly used to help with comparability of data. But in the United States and in most high-income countries, the threshold is 20 completed gestational weeks. Also, most countries do differentiate between spontaneous fetal death, including stillbirth and miscarriage, and induced termination, which we call abortion here. So this is one of my favorite slides. To make the case for why stillbirth matters for health equity, we need to start with why stillbirth matters for public health generally. And the reason it matters is because there are a lot of stillbirths. This is a pie chart showing all global deaths to mothers and children under 5. I think it's from 2020. There are about 5 million deaths to mothers and children under 5. And stillbirths account for 1/4 of those deaths. That's very conservative as an estimate because here, using global data, we're counting stillbirths from 28 weeks on. If we included stillbirths from 20 weeks on, that red slice of the pie would be a lot bigger. I also want you to note, I'm doing advocacy as I do this presentation, my terminology. There are live-born newborns, and there are stillborn newborns. And again, the parents and the providers in the room understand that survival status doesn't determine whether you're a newborn baby or not. Okay. Another point to note about stillbirths at the global level is that 40% of those stillbirths occurred during labor and delivery. The picture looks really similar when we go to the national level. This is data from the United States from 2019. The pie would look basically the same if I use the latest global data, which is only from 2022. So here we see that if we're looking at the 42,000 infant deaths in the United States, half of them are stillbirths, about equally divided between those stillbirths above and below 28 weeks. 50% of infant deaths are stillbirths. And what's not typically understood is that there are twice as many stillbirths in the United States as there are deaths to children aged 1 to 14 from all causes combined. Accident, flu, whatever. So these two slides together at the global level and the national level hopefully make the case for why stillbirth matters for public health. So now we're going to go to, all right, there's a lot of stillbirths. Why does stillbirth matter for health equity? So the stillbirth rate is defined as the number of stillbirths per 1,000 total births, meaning live births plus stillbirths. And this is a map from the most recent global country-specific data. That global data is collected by the UN Interagency Group for Child Mortality Estimation, UNIGME. And this is a heat map with the darker colored countries having higher stillbirth rates than the lighter colored countries. You can see that the stillbirth rate in sub-Saharan Africa and South Asia is roughly 12 times higher than it is in parts of the world with higher income countries. That's a huge disparity. Also, within countries, there's great disparity as well. In Australia, the stillbirth rate in Aboriginal and Torres Strait Islander moms is 50% higher, 1.5 times higher than it is in white families. In Ireland, the stillbirth rate in poor counties is 3.5 times higher than it is in wealthy counties. And in the United States, the stillbirth rate in black families is double that in white families. And I think these statistics are important because the inequities are not only visible between regions of the world, but inside countries. We can see the inequities in our national stillbirth rates from this chart. This shows stillbirth rates in the United States from 2019, and again, the data are not that different in the subsequent 3 years, broken down by race and ethnicity. You can see that the stillbirth rates in black families, Native Hawaiian and other Pacific Islander families, and American Indian, Alaska Native families are much higher than in white families. And they are also much higher than the national stillbirth rate, which is 5.7 per 1,000 total births. And here we're talking about a stillbirth definition of 20 weeks and up. This figure is from a fairly old paper from 2011, about 15 years old. And unfortunately, I keep reusing this figure because the picture hasn't changed. This shows stillbirth rates from 1950 to 2005. And the orange triangles show stillbirth rates in black families. The blue squares show stillbirth rates in white families. And you can see that back in 1950, the stillbirth rate in black families was twice as high as in white families. And in 2005, the picture is the same. The stillbirth rate in black families is double that in white families. And in fact, a couple of weeks ago, I actually crunched the latest numbers. I went back to the 1950 data. I found the vital stats data, and then I found the most recent data from 2022. And actually, the disparity has actually worsened. The ratio between black and white stillbirths back in 1950 was about 1.9, and today it's 2.4. So this is kind of a busy slide, I'm sorry, and I'm going to walk you through it, but I think it's worth it, and it'll show up a little bit later in my presentation. The blue bars represent black stillbirth rates, and the orange bars represent white stillbirth rates. And this is data from 10 years of births in New York City between 2009 and 2018. There were about 1 million births during that time period, and this is from research that I carried out. And I broke down the stillbirth rates in black and white families by a whole bunch of different characteristics. There are two fetal characteristics, the stillbirth rate by gestational age there on the left, and by fetal sex. And then also I broke it down by three maternal characteristics. That's maternal age, maternal education, and also the borough. These are New York City data, so this was the borough of mom's residence. There are 5 boroughs in New York City. And the takeaway here is that you can see the blue bars are higher than the orange bars. So no matter how you slice the pie, black stillbirth rates are higher than white stillbirth rates, every single subcategory. And in fact, for example, if we look at some of the black and white stillbirth rates, we can see that the black stillbirth rate is actually 3 times higher than the white stillbirth rate for male babies. It's about 3 times higher for older moms. And it's also about 3 times higher for moms who happen to live in Staten Island.
Sam, can I ask you a question?
You bet.
I understand this is a decade worth of data.
Yep.
Do you have any sense of like that if this is consistent with other decades?
So the question was, would we see this same picture if I took another 10-year period?
Is it getting worse historically?
Is it getting worse, or is it about the same? I mean, as a scientist, I would say I need to check the data because I want to emphasize this is all 100% evidence-based, the data that I'm presenting to you. So, So it's interesting. I would expect that the disparities are worse, a little bit worse now than they were, say, if we were looking at the 1980s. And the reason I say that is simply because of the prior slide where I told you that I had crunched the numbers, and the national stillbirth rate ratio between black and white families has increased. However, this is New York City data, and the New York City stillbirth rate is actually much higher than the national stillbirth rate. So this situation is a little bit different. Things do seem to be getting a little bit worse in terms of stillbirth rate disparities over the last number of decades, but yep. Yes?
When you say black family versus white family, is it black mother or birthing person? Does it matter interracial family?
Great question.
How are you defining it?
Yeah, so the question was, how am I defining, or how are we defining a black stillbirth rate? Is that is it a mother who is black? What if dad is black and mom is white? It's interracial or multiracial, etc. So thank you very much for that question. It's so important. The slides that I'm showing come from different data sources with different ways of defining what it means to be a black stillborn baby versus a non-black stillborn baby. Up here, the data that I used are from the census, and so race is self-identified in census data, and I excluded multi-race babies from this analysis. And the baby's race in stillbirth data in New York City are aligned with the mother's race. But that's a really great question. I can tell you that I did repeat my analyses using different ways of defining Black families. You see this is non-Hispanic Black families. I did repeat the analysis, and I'll be sharing some more results from that later, in all Black families, Hispanic and non-Hispanic, and I didn't find much difference. And in terms of the national data that I shared, again, those come from Vital Stats, and that's self-identified race. Thank you.
And Sam, I know that data had been pulled in a while. Can you speak to that? Where you said you were the first one that it showed.
Oh, right, yeah. I will also say that I randomly was the first, I was the first person to publish on stillbirth rates in New York City. Can you believe it? It's just crazy. There's millions of stillbirths that occur in New York City, and nobody had pulled that data before me. And I'm just some random, person who was asking a question about stillbirth in New York City. So there's a lot of untapped information out there that we can use to answer questions of import. And I just thought it was crazy. They were like, great, you want to look at stillbirth? Fine. So that was, anyway. I also want to emphasize that the Black-white disparity in stillbirth rates persists into subsequent pregnancy. So this is, these two points are from different studies. But as many of us know, unfortunately, if you've had one stillbirth, your risk of having another stillbirth is higher, about double. Depends on the reason for the stillbirth and if you know that reason. But for Black moms, for African American moms, that risk is 3 times higher. I just also want to point out that these are all facts and figures, and I believe, as I'm sure you all do, that they relate directly to mental health outcomes in moms and families, and directly to the experience of moms and families as they go through subsequent pregnancies. So there's a lot of emotion and life behind these numbers.
Sam, can I ask a question?
You bet.
Is there a relation between a miscarriage, like that qualification before 20 weeks, and that connection with stillbirth as well?
In terms of recurrence. So the question was, sorry, let me see if I can go back up. The question was kind of, is the picture the same for miscarriage? And again, I don't want to say the wrong thing. I'm sure there are many miscarriage experts in the room, and it's not a black and white, obviously, division. It's an somewhat of an arbitrary division between where kind of the gestational age threshold is set, and really miscarriages, stillborn babies, and newborn deaths are all on a continuum. With a merging of causes and so on. I'm sure that the picture is quite similar, certainly for late gestation miscarriages. I don't have the data, though, with me yet. So I also wanted to point out that just as I showed you that if you look just at the national stillbirth rate, it hides a lot of disparity within a country. Same thing with blanket designations of race, ethnicity. So this is a slide just showing the breakdown of Hispanic stillbirth rates in different Hispanic subgroups. This is also vital statistics. And you can see a range of stillbirth rates going from Cuban American the Cuban American stillbirth rate at 3.9 per thousand total births, to the stillbirth rate in babies of other and unknown Hispanic origin at 5.8. It might not look like such a difference, but actually the stillbirth rate in that lowest group there with unknown Hispanic origin is 50% higher than the stillbirth rate in Cuban Americans. It's a huge difference. And
Do you think it's genetic or like socioeconomic or like everything?
do I think it's genetic or socioeconomic, the difference is? No, I don't think it's genetic. I think that there are, I'm radically not an expert in Hispanic stillbirth research, but I would say that, there are maybe sociocultural factors that are different. Access to care is going to be different. Where you live, if you're Cuban American versus Mexican American, is going to be different. All kinds of things.
Sam, can you give an example of other and unknown Hispanic?
Yeah, other and unknown Yeah, what is inside the other and unknown Hispanic category? I meant, did I? Darn it. I took these data from the Vital Stats report, the most recent Vital Statistics report, which was published in 2024, and they do define that category, and I did not include it here. I think this will include, so when whoever is filling out the information for baby on race ethnicity is going to have an opportunity to check a box on race ethnicity, and then if they check Hispanic, they will also have the opportunity to designate what type of Hispanic group baby identifies with. If that box wasn't checked, it's going to go to other and unknown. So this probably partly has to do with crappy data. Whoever filled out that data on baby maybe didn't fill out that next level for baby's race ethnicity, or the parent may have chosen not to identify any further.
It is often a problem in the Hispanic community that the way, I don't know if you have experience with this, but like with people that you work with, that the way that classification is set up is highly problematic and people don't feel they identify with it.
So Brittany's saying that the options to check on that form often are problematic for Hispanic families who feel that they don't identify with any of the options to check, and so that would be another reason. Thank you. Yeah, thank you. Or they could come from multiple Hispanic subgroups, mom from one and dad from another. So this table comes also from those 1 million births in New York City over 10 years. And I just want to orient you that, each of the columns is a different race, ethnicity, black, white, Hispanic, and so on. And you can see the stillbirth rate, that's stillbirths per 1,000 total births, along that first row. And then it's divided into whether whether mom was born in the United States or not. It's divided by nativity status. Was mom U.S. born or not? And you can see that for every race ethnicity group, the stillbirth rate is higher if you were born in America than if you were not. You can also see that final row, that on the bottom there, is the ratio between the stillbirth rate if you were born in America or not. And you can see that disparity is greatest for black families. So for black families, the stillbirth rate, if you're black and born in the U.S., is 15, almost 16 per 1,000 total births. Yep.
Can I ask a quick question?
You bet.
Did this take into account any of the related sort of compounding issues that we see more prevalently in the United States, like gestational diabetes?
So this is just raw data, and in a few minutes I'll show you some results from some regression analyses. So yeah, these are just raw data that do not take any other factors into account. Another thing that is important to note when we think about stillbirth and health inequities is the disparity at a geographic level. And again, these are our 1 million births from New York City, and they're divided. So these are the bars, the orange columns are stillbirth rates in all 55 New York City neighborhoods. And they're organized into 5 groups according to the 5 New York City boroughs. And you can see that there's a huge range in stillbirth rates inside New York City, from 15.1 per 1,000 total births in one of those neighborhoods in Brooklyn to a low of 2.8 in one of the neighborhoods in Staten Island. And I went to take a look at what it means to have a stillbirth rate of 15 per 1,000. That stillbirth rate in one neighborhood in Brooklyn, in New York City, is higher than the stillbirth rates in Myanmar and Papua New Guinea. Now, those are countries in Asia that have a per capita income less than $3,000 a year. So the stillbirth rate in this neighborhood in Brooklyn is worse than a couple of countries with an annual average income of about $3,000. At the same time, that low stillbirth rate there is equivalent to the lowest stillbirth rate in the world. It's in Japan or Iceland. Here's Utah. And again, just as in New York City, we see that there's a big variation across the counties, geographic variation in stillbirth rates. So the darker orange areas are counties with higher stillbirth rates. And we can see that the areas with those higher stillbirth rates overlap substantially with the areas that are more heavily populated by American Indian, Alaska Native residents in the eastern half of Utah. And there's also an overlap with counties that have higher populations of Native Hawaiian and other Pacific Islander folks in the northwest corner of the state. This is data from the Department of Health. Thank you, Nikki, wherever you are. I don't know where you are. And this is something that I always like to emphasize. Stillbirth rates also vary by federal status. So welcome to the map of the 5 populated U.S. territories. Those are in green. There are 2 in the Caribbean, Puerto Rico and the U.S. Virgin Islands. And there are 3 in the Pacific, the Northern Mariana Islands, Guam, and American Samoa. The stillbirth rate in 3 of those territories is not available for a variety of reasons. But the stillbirth rate in Puerto Rico and Guam is woefully high. In fact, the stillbirth rate in Guam, a U.S. territory, at 13.3 per 1,000 total births is the same as in Morocco, with a per capita income of $4,000 a year. It's quite problematic, and it's quite difficult and challenging to study stillbirth in these U.S. territories because the numbers are very small, and that makes it hard to get sort of statistical significance. Here's another kind of gnarly slide. I'm going to walk you through it. There's race ethnicity variation also in causes of stillbirth. So these data are national vital statistics data, and they show the race ethnicity breakdowns from the 5 most commonly selected causes of stillbirth. I'm not going to do a lecture on the word cause. I have a lecture on the word cause, but we'll just go with it. You can see white stillbirths are shown by the light green bars, Native Hawaiian, other Pacific Islander by the purple, Black by the light blue, Asian stillbirth rates are the dark green, and American Indian, Alaska Native are the orange. So based on these data, if we wanted to reduce white stillbirth rates, of course we'd look at the unspecified cause, but we would next go to stillbirths from complications of the placenta, cord, and membranes, and we'd start to do research on how we can reduce stillbirths from that causal group. But to reduce Black stillbirths, In addition to looking at that causal category, we'd also want to look at maternal complications of pregnancy and maternal conditions unrelated to pregnancy. Both of these causes are much less common in white stillbirths. To reduce American Indian stillbirths, we'd want to unpack that all other causes category. And to make headway on Native Hawaiian and other Pacific Islander stillbirths, we'd need to address those with an unknown cause, as well as diabetes-related causes. So the takeaway message here is that not only are stillbirths inequitably distributed across race, ethnicity, but causes can also vary by race, ethnicity. This is that same slide that I walked you through earlier, and I want to point out one other message, which is that risk patterns also vary by race, ethnicity. Remember that all black stillbirth rates are higher than white stillbirth rates, no matter how the pie is sliced, but take a look here, and we can see that the stillbirth rate for black births is highest in older mothers, but for white births, it's highest in teenaged mothers. So think about how that might relate to prevention activities. The stillbirth rate for black births is highest among boy babies, higher than girl babies, but for white babies, there isn't much of a difference. And for black births, the highest stillbirth rates are in Staten Island, but for white births, it's in the Bronx. Again, think about how that might relate to prevention activities. Okay, this is the toughest slide to explain. I'll just touch on it briefly. This is from my own research on associations. I was looking at possible associations between proxy measures of structural racism and stillbirth in those 1 million births in New York City. And one of the measures I used to capture structural racism is called the Index of Concentration at the Extremes. It's very unfortunately nicknamed ICE. Yeah. ICE models the relative privilege or disadvantage of a neighborhood. After I controlled for potential confounders, we found that black mothers living in New York City neighborhoods of privilege had a 54% higher risk of stillbirth than black mothers living in neighborhoods of disadvantage. There was no evidence of associations in white moms. So we hypothesized that this could have to do with reproductive health care that is worse for black women in neighborhoods of privilege, perhaps due to provider bias or racism within the health system, or possibly black women experiencing greater or more constant exposure to stress in neighborhoods of privilege, for instance, due to microaggressions or interpersonal racism. Yes?
Sandy, you think that the statistic would carry over into maternal mortality statistics as well?
Do I think I would see this in maternal mortality? Again, I don't want to opine on an area that I don't do research in.
Sorry, Sam.
But I will say that this was not a finding in alignment with much of the literature. However, much of the literature looks at, well, there's almost no literature on structural racism and stillbirth, but the little that there is lumps all babies together and doesn't look separately in black and white births. So I think bear with me for a little bit longer. I know this is an awful lot, and I just want to share some of the next few slides with you, and then I'll be done with talking about this. But the variations in the degree and type of stillbirth risk across race, ethnicity, and other characteristics means that research and prevention have to be tailored to those groups, or at least take that into account. But research typically does not do that. This chart, also from my own research, summarizes analytical approaches that were used in 100 reports of black-white disparities in stillbirth rates. And that's shown by the blue bars. The orange bars show authors' explanations for the disparities that they found in their stillbirth data. By far, the most common analytical approaches that were used to explore racial disparity in stillbirth rates looked at maternal and fetal characteristics. For example, gestational age or birth weight, maternal BMI, maternal medical conditions. Almost none of those reports used any structural or health system factors to explore those disparities. The research is almost non-existent. And also, studies of racial disparity in stillbirth rates rarely examine some of the highest risk groups. So here we remember that the stillbirth rate in Native Americans and Alaska Natives is quite high. And yet, the review that I did of racial disparity in stillbirth rates found that only 16% of studies even looked at Native American stillbirth rates. So in 2016, the Lancet Medical Journal published a really important series of papers called the Ending Preventable Stillbirth series. And that series of articles included a call to action. It's here on the screen. It included a call for countries to set and then to try to meet stillbirth equity targets. The International Stillbirth Alliance, which I'm a past chair of, we were worried that people would forget about this call to action, and so we created a scorecard to track progress against that call to action. And here on the screen, with a lot of writing, is the 2019 version of the scorecard. And basically, red is bad, orange is so-so, and green is great. On the left are the 20 indicators that we look at as we assess progress towards the call to action. And on the right are columns for the different global regions, including Asia, Africa, and Latin America. So as I said, red is bad, green is good, and gray means there's no data. You can see that most countries had not only not achieved a global stillbirth target, which is 12 per 1,000, but they had not even set a target. And most importantly, when we look at the call to set and meet a stillbirth equity target, there's no data available at all to measure progress. We don't even know where we're at. So this is my second to last slide, and I think that, this basic pair of pie charts kind of sums up the crux of the sort of stillbirth inequity crisis. So on the left are live births, and on the right are stillbirths. This is national data from 2022, so hot off the press. It's the most recent data available. And you can see that while Black births constitute 14% of all live births, they make up 26% of all stillbirths. Essentially, there are far more Black stillbirths than would be expected in a situation of full health equity, meaning if Black and white stillbirths occurred in proportion to Black and white live births in the population. So I adapted this figure from, as you can see, the citation down there. And I would say, despite the persistence of a doubled risk of stillbirth in Black as compared to white births, the research on why this is so is very sparse, and it's focused primarily on individual level factors related to the mother and the baby. There's very little research on stillbirth inequities in relation to structural factors such as structural racism. As we know, structural racism is an interdependent and self-perpetuating complex of institutional practices, laws, and policies that oppresses members of a group because of their membership in that group. Structural racism has been associated with many adverse health outcomes, ranging from infant mortality and preterm birth to birth weight and severe maternal morbidity. And as I've shown, it's also associated with stillbirth. Research to reduce inequities in stillbirth rates cannot ignore these major structural features of our nation. So I hope that I have adequately conveyed why stillbirth matters for global public health, for national public health, and for health equity. I would say that achieving health equity requires equity in stillbirth prevention and research, and it also requires equity in stillbirth care. And so with that, I'm going to hand it over to Stacy unless there are other questions. Thank you very much for your attention.